Welcome to the Nurse Mark Podcast, where we talk about everything health, happiness, cannabis. We'll delve into all aspects of what it means to live a powerful, healthy life. Everything from exercise to nutrition to mindfulness, and how to use cannabis as a means to alleviate some of the most common health issues we face. My motivation and passion come from the fact that I personally had to explore all these areas to deal with lifelong depression and mood disorder. For me, it's personal. So sit back, relax, and enjoy. Hey guys, welcome to this week's episode of the Nurse Mark Podcast. This week I have as my guest, Dr. Jordan Tishler. Now, Dr. Tishler is a Harvard-trained physician, worked in the emergency room for many years, but a few years ago, really started to dive into cannabis as a medicine. And lo and behold, he is one of the biggest advocates of using cannabis as a medicine. And he has a practice called inhaleMD here in the Boston area. And he works tirelessly with patients and he advocates at a very professional level for cannabis as a medicine. You're really going to enjoy this episode. We talk about drug interactions. We talk about how people are using it, what the patient population he's working with. And we talk about sex and cannabis. Well, you got to wait till the end. It's a good conversation. All right. Sit back, relax, and enjoy. Welcome to the next episode of the Nurse Mark Podcast with your host, Nurse Mark. Today, oh my gosh, my guest, Dr. Jordan Tishler. Dr. Tishler, how are you today, my friend?
I'm great, my friend. It's good to be here. And thanks for having me on.
You know what? It's great to have you back on again. I love the conversations we get into because they go pretty deep. And you're in the field every single day, working with cannabis as a medicine, treating patients. And you know what? Let's talk about that.
Absolutely.
Let's talk about that. You are treating people effectively with cannabis as a medicine. So what are like the top ailments, diseases, issues that people are facing that they come to you and say, hey, doc, I've tried all of these other things, not really successfully, somewhat maybe, but I'm really curious about cannabis. You know, what are you working with?
Without question, pain is the number one, right? And of course, pain is a pretty big topic, right? I mean, we can be talking about things that are, mechanical, like osteoarthritis, or we can be talking about people who have some sort of a neurologic condition like neuropathy that causes pain. And then sort of the third category, at least the way I think about it, is people with autoimmune or inflammatory mediated illnesses like rheumatoid arthritis and Crohn's disease and such like that. And what's really interesting, and I think, again, kind of tends to raise some eyebrows amongst the colleagues, is that we tend to think of each of these types of pain as being very different. And there's truth to that kind of on the mechanistic level, but ultimately pain, funnels down into our perception of it, regardless of its actual cause. And so we tend to think that, certain medicines treat neuropathic pain and certain types of medicine treat mechanical pain, et cetera. And so if we can say, well, cannabis treats pain, a lot of my colleagues kind of go, well, what do you mean? What kind of pain? Can you be more specific? And the reality here is, that most of the studies have been done with sort of neuropathic type pain, the MS patients and such like that.
Well, I think that's because there's not a lot of options that are really effective with neuropathic pains, right? So when you look at all the buckets.
Yeah. I mean, I think the truth is that reality is that there are not a lot of options for anybody's pain at this point. I was absolutely floored this week to take care of a patient who had a vehicle accident and had been in the hospital for a week with 11 rib fractures and a clavicle fracture.
Oh, and that was a pain.
Oh, like you can't think of a worse set of fractures right there.
No, because you breathe.
Right.
You have to, right? You break your arm, you can sling it and you don't have to move it, but you breathe and those ribs move and oh my gosh, the pain.
It's inescapable. But the point of the story was that he got sent home from the hospital with Tylenol, ibuprofen, and gabapentin.
Mm-hmm.
Now, I am one of the stingiest bastards in the world when it comes to opioid medications.
Right.
Because, I spent my career doing emergency medicine where we see lots of problem use. But when people break a bone, that's, I think, one of those times where opioids sort of would be reasonable. But he's miserable because he had none of those things. So we've put him on some cannabis. And, it's too soon for me to say whether it's really done much for him.
Right.
3 days ago. But hopefully he's going to get some benefit out of that.
That's good. That's a good point to talk about. Maybe, that pendulum is swung on prescribing opiates, right? Now opiates, I feel, are a very good pain management tool when used correctly, right? But it's swung in that direction because of this awful epidemic of opiate overdose, right? So it's swung in that far side of, oh my gosh, I'm just not going to prescribe them anymore, and people are going to suffer.
Absolutely, and just, for reference, we have to remember that most recent numbers were sort of 40,000 Americans dead from opioid overdose. Right. I think those are 2017 or 2018 numbers, so it's a little out of date. But the point is, roughly 1/3 of those deaths were due to prescription opioids. Mm-hmm. So the remaining 2/3 were street opioids, that sort of thing.
Right.
But we have to compare those numbers against something for frame of reference. We know that there are 4 million Americans with chronic pain, maybe higher than that, but that's sort of the number that we know. So you're comparing 40,000 to 4 million, you start to realize that cutting off the pain management for those 4 million people is just not the right approach to this problem. Mm-hmm. Another way of looking at that is that 40,000 is roughly the same number of vehicular deaths in the year. Mm-hmm. And we don't stop driving, right? We drive, we make rules to be safe, and we make devices to increase the safety of our car, but we don't say this is beyond our ability to tolerate. We just have to keep a certain amount of risk. So I think that, this is a great example of what happens when we let politics and frankly, unfortunately, public opinion dictate medical management.
Right. And you know what? It just occurred to me that cannabis can be one of those safety measures when using opiates, because we know that cannabis decreases the amount of opiates you need to take to have the same effect on pain relief.
Absolutely.
So, oh my gosh. Boom, a little light goes off. See, great conversation, Doc. This is an epiphany for me right here.
The funny thing is, I have a lot of patients who come to me and they say, Doc, I'm on XYZ medications, opioids or benzos or something, and I want to come off. And in my head, I'm thinking, well, it's quite possible that you actually need these things, or some of them, maybe not as much as you're on now. And so adding cannabis, just as you said, we see in various series a 40 to 80% drop in the necessary dose of opioids. That's wild. That's huge, right? That's taking somebody from, 100 morphine equivalents down to 20 morphine equivalents. That's amazingly safer for them. If we're getting the same pain control, then that's a real win. But the flip side is that I think that we've, kind of going back to the pendulum swing, we've got this kind of weird situation where now we have the patients, citizens who have, internalized this message that these things are so bad that they really need to get off them.
And that is the messaging that's out there in the general public right now. That's the sentiment. Hey, pharmaceuticals are awful. Let's just get away with them. And I'll tell you right now, I don't feel that way. Like, pharmaceuticals are an amazing tool when used correctly, and augmenting with cannabis, right?
Listen, if you bang your thumb while you're hammering in a nail, after the first 2 seconds, you probably don't blame the hammer. Right? I mean, the hammer didn't do it. You did it,
Hammer.
Damn hammer. Right. That's after you hurl it across the room.
Absolutely. Oh, you've been over to my house. Yes. That's right.
God. Right. But then you throw the hammer, that and you have the next project for fixing what you broke when you threw the hammer. So it's all good. Mm-hmm. But bottom line is, you're exactly right. It's like we have to view these things as tools and use them with the sort of care and wisdom that we would with any tool. You wouldn't let your 5-year-old play with your table saw, right? That's a recipe for disaster. Mm-hmm. Similarly, you probably don't want to write a prescription for, 300 tablets of oxycodone for somebody every month without at least really, really thinking about what you're doing and mm-hmm. coming to an agreement and having some sort of monitoring, et cetera. Cannabis is the same thing. You can overdo cannabis. You can feel sick. You can certainly scare new patients away from using it. You can mm-hmm. their tolerance. You can create dependence. All of those sorts of things, just like any tool that gets misused. I think the nice thing about cannabis is it's generally safer than many other medications, pharmaceutical or otherwise, largely because it doesn't cause depression of our respiratory drive. So we don't, if you take too much opiate, you stop breathing, and that's a problem.
Yeah.
That doesn't happen with cannabis. So this is definitely in the plus column. But, that's become such a selling point amongst the advocates that they're sort of overlooking all the other sort of less lethal, but still important, reasons to be thoughtful and careful with this mm-hmm. as a medicine.
So when you're working with a patient, when you're working in the cannabis space, is it a different relationship where the patient has to take on more responsibility for their actual care? Do you see that? Is it a different relationship than, say, in the past when you would meet with a patient and it was just about pharmaceuticals? Did they look to you to say, this is exactly how I want you to do it, and they just walked away and did it? Are they more responsible now for their own care in the cannabis space, or is it still sort of that?
I actually think that there is a strong messaging sort of from the advocacy side that this is something you kind of dabble with yourself. And, it comes out people saying, everybody's different and stuff like that. Well, I think it's great and important for people to take an active role in their healthcare. Absolutely. Mm-hmm. And I view my relationship with my patients as a partnership. And I mm-hmm. view myself as sort of a trusted advisor. Mm-hmm. But by the same token, I think this sort of throw your hands up in the air and say, nobody can tell you how to do this, or nobody can tell you how to sort of start it and manage it, is kind of an excuse for letting people just sort of sell people a lot of stuff. Oh, try this product, try that product, blah, blah, blah. Mm-hmm. And I have patients who, they come to me and I give them a pretty specific set of recommendations. And then they used to, before COVID, go to the store, and the store people would say things like, oh, I don't understand what your doctor's saying. Forget what he says. I'll tell you what to do. And then they come home with $400 worth of all the wrong stuff. And then they call me up and say, Doc, why isn't any of this stuff working? And I said, well, what are you doing? And then they talk about it. And I said, well, the reason it's not working is because it's not going to work that way. And mm-hmm. It's why I didn't recommend any of those things to you, right? I recommended this because I think it would work. So, unfortunately, some of the time what I hear from my patients is, gee, doc, you were right. I should have listened to you the first time.
Right.
And I don't get any gratification out of that because I really just want them to get to the finish line, without the minimum of fuss and effort.
Yeah.
To your question about responsibility, frankly, I think there's not a lot of difference, because when I would write a prescription in the emergency room, the one part of that that's different is that when people go to the pharmacy people aren't changing the plan.
That's what I was going to say. The pharmacist never says to the patient, oh, I don't know why your doc is prescribing this medication. This one over here is much better. Let me just switch this up. That doesn't happen. They just fill it, and then they talk about, any questions that are issues like interaction, which we'll get into drug interaction in just a little bit in the conversation.
On occasion in my career, I have written prescriptions incorrectly or whatever, or there was a cheaper substitute. And then the pharmacist calls you, right? And says, hey, doc, what do you think about this? Or did you really mean it that way? And again, that's a great sort of collegial interaction.
It's checks and balances, right? That's
Absolutely.
all it is.
But, so on the prescription that I write for all of my patients in the cannabis world, because I do write down what would be a prescription, at the top of it, it says in a red box in red letters, it says, dear, patient service advocate or whatever, please do not change the plan. If you have concerns, please call me. Here's the number. You know how many times I've gotten a phone call?
I was just going to ask.
Yeah, none.
No.
It is an interesting bit of conflict in the cannabis industry, because to the extent that clinicians tend to be very specific and tend to aim for sort of the minimum effective dose and that sort of thing, at a superficial level, and unfortunately, I think this is the level at which most cannabis businesses are viewing us at the moment, this stands in the way of their unfettered sales, right?
Of course.
And
their motivation is different than what your motivation is. Your motivation is for your motivation primarily, your primary one is for that patient to feel relief.
Yes.
Their motivation primarily, now they may want the person to feel relief too, but their primary motivation is let's sell them as much product as we can because it's about
right. And I think that that dynamic probably existed in pharmacies when they were sort of coming into invention sort of 100+ years ago.
Right. Yeah. It was a Wild West then, right? There was a pharmacy on every street corner and everybody was doing their own formulations. And it was like, do I go to pharmacist Jordan over here or pharmacist Mark over here who's got these different elixirs? Yeah, it was Wild West. And that's what we have now still.
But I think, if you look back at the evolution over those 100 years through a process of regulation and perhaps some enlightened self-interest, we've realized that, selling medicines with some precision is actually better long-term because you have better patient outcomes, which means that it not only legitimizes the medical industry, but it also means that people come back and to your pharmacy and say, I like to buy from the CVS because they treat me well and because I get what I need and because they don't seem to be pulling the wool over my eyes and stuff like that. So I think that, as the industry matures, if we're lucky, we'll get that kind of thought process with some of these medical dispensaries so that they become more like pharmacies in that they are more reliable for the products that they have and the products that they dispense. Unfortunately, right now, I think the industry is very strongly messaging, oh, you don't need a doctor, just come to us under the recreational side and we'll treat you.
Right.
And I think that, that's unfortunate. And,
it is unfortunate because the unintended consequences, a bunch of people try cannabis. It's not effective for them because they aren't guided or coached or given the experience and education that you or I might have to get them to the right product that's going to work for them. They try it and then cannabis is off their list of things that they will try in the future. And if it
doesn't work, that's the good news under that scenario, right? And if it works too much, then then you've made a prohibitionist out of them. Like, oh my God, I can't believe how bad that stuff was. And, especially with older folks, I always look at it as you pretty much get one shot with them. And if you blow it, they're pretty unlikely to come back around and give it another try.
Well, yeah. Yeah, because, cannabis, THC specifically, right? When you have that biphasic property and you have too much and you have that panic attack, who's going to want to do that again?
Nope.
Nobody.
And it's
an
miserable
feeling
when that happens.
Yeah, you're done at that point. So, well, that brings up a good question. What's the age demographic of the average person that you're dealing with? Is it 65, 70, or is it 45, 50, or is it all across the board?
Well, I think, and average is kind of misleading in this situation. So I think my patient population is sort of three different groups. Clearly, the largest group are older folks in that 65 plus group. Then there's sort of a middle-aged group who, by and large, have cancer of some sort. And then there's a sort of smaller group in the 20s and early 30s who have kind of a mixture of things, but generally pretty severe anxiety.
That's
not sort of garden.
That's what I see. That's exactly what I see within those sort of demographical buckets. Those are the things that people are dealing with and why they're coming to cannabis.
Absolutely. And then I have a smattering of people with, horrible neurologic diseases like ALS, and smattering of children and adults who have autism, for example. But in general, those three buckets, as I mentioned, are kind of the big ones.
Boy, exciting times. It's just there's so many different things that cannabis can be utilized to have a positive effect on. I think that's what drew me to it and really fired up my passion for this whole area of medicine. It's so all encompassing.
Yeah, and it's fascinating the way in which this simple. Let me rephrase that. There's nothing simple about cannabis, but on its surface, here's a botanical plant that produces chemicals that can help us treat symptoms across such a wide range of illnesses. Right? This is not a medicine that is just for ALS or just for MS. And again, that sort of makes some of my colleagues wonder what we're talking about. But the reality here is that what we're really doing is symptom management. And so this particular substance really gets in there and helps with, a range of stuff because of the way it interacts with our neurology and with this endocannabinoid system that we all have. And I think that that's brilliant. And it's really instructive for how we should think forward about medication development in terms of being able to develop medicines that, again, affect at that sort of higher level so that we get broader benefit from it. And also ones that aren't as simplistic as here's one molecule in a pill. Because, I think that that's been a great model for 150 years, but we've probably missed a lot of the boat by looking for that sort of one object as opposed to sort of
like lock and key, right? If you have other things that open up other receptors to accept whatever it is, that one molecule you're working with, it seems to make sense that, in the complexity of the human being, right? There's so much that we don't know, but it just kind of makes sense to me. I share this a lot. I was at a conference in Tel Aviv, medical marijuana conference a year ago. And so it's all the top researchers in the cannabis industry really presenting their material. And one of the presenters, and I don't even know if it was Dr. Mushalem, who said, it's not that cannabis is specifically the best pain reliever or appetite enhancer or any of the things that you use it for. It's not that it's the best in class. It's that it has an overall positive effect on the human being in all of those areas, that it allows them to step out of whatever they're experiencing and start to participate in life. Right. So that, I was floored when I heard that. It was just an amazing moment where he said, that's it right there.
Yep.
Just all of those paradigms.
No, I think that, one of the things that people ask me often is, is it a pain reliever? And I say, well, technically it's not a pain reliever. If you use cannabis for knee pain and you sit there and you think, does my knee still hurt? The answer is yes, I can feel that it still hurts. But what cannabis does is it divorces that perception of, yes, it hurts from the suffering, the reaction, the emotional importance of that pain. And so, yes, my knee still hurts, but I don't care. It's not bothering me anymore.
Yes.
So now I can go for a walk.
It's just a different mechanism of disconnecting from that painful stimulus, which is going to be there, right? If you have injury or something that's chronic, it's going to be there.
Unless you replace the knee, that knee is going to hurt.
Bingo.
Yeah, absolutely. And I think that, as you were saying, being able to get back to life, to enjoy life, those are really important details. And they have important downstream cascades, which is to say that somebody with, severe knee pain who doesn't get out and take a walk is not only sort of missing the joie de vivre, but they're also sitting on their butt and getting fatter and developing diabetes. And
it's that slope. And it really is like that. Like diabetes, like the type 1 happens like that. Yes. But type 2 diabetes, which is, would you agree is the most prevalent, right?
Without question.
It's a slippery slope. It's a slippery slope. You don't start out as a type 2 diabetic. You start out fine. Then all of those things happen. You gain a little weight. You don't eat right. It triggers things in your body. It becomes that whole metabolic syndrome. And then all of a sudden, you're a diabetic. So you're right. So stepping out of that and getting off the couch and moving and participating in life can be life-changing.
The best treatment for type 2 diabetes is exercise, because
absolutely
the problem is insulin resistance, which happens at the level of muscle uptake of the sugar, right? So, but the problem is the more your knee hurts, the more you sit on your butt, the worse your diabetes gets, the more now you develop neuropathy or other painful things.
Right.
I mean, it just really is a snowball. And if we can get people to feel better and then get just a modicum of exercise, that sort of arrests that slope, as you say.
Absolutely. I'll give you a perfect example. I had 2 herniated discs. I was scheduled for treatment, and I was at the spine center at New England Baptist, world-class organization, right?
Yeah,
top in spine injury. And, my doc told me, the first thing she told me was, when you're in a flare-up, the best thing you can do is go to the gym and move. Whatever you can do, whatever you can make happen, even if it's 25% of what you normally do, move. And so I actually was able to avoid, at the moment when I was scheduled for surgery, was going in a week before the surgery. I started to feel better. I called the doc and said, listen, should I have the surgery and just be done with it? He said, I don't want to see it till you're dragging your ass across my carpet in the waiting room. Like, that was literally what he said, right?
Yep.
And so I went back to the gym, and that was 6 years ago, and my back is spot on, right? That's an example of, if you can get people back into life and moving, it can have a profound effect on their health. So this seems like a perfect spot to take a little break for the Nurse Mark Nuggets. So hold on, folks. We'll be right back. Hey guys, Nurse Mark here with this week's Nurse Mark Nugget, brought to you by, Pro9 Wellness. Pro9 Wellness is a new brand of topical CBD patches. 96 hours of continuous relief. Now, I used one on my left shoulder that's been a little sore for 6 months at the gym lifting, and I used it, and I went to the gym and I worked out, and I did not have any pain. And it continued for the next 96 hours. Amazing. Check them out at pro9wellness.com. Ready for this week's nugget? Okay, let's do it. Timothy Leary, very famous activist and Harvard professor, late 60s, 70s. Really famous for his advocacy and use of psychedelics, LSD. That was the big thing he was known for. But what a lot of people don't know is he was arrested for marijuana possession in 1968, and he challenged in the Supreme Court the Marijuana Tax Act. And he said, hey, you can't apply the Marijuana Tax Act. It's against my constitutional rights because it's against my Fifth Amendment rights. It makes me self-incriminate. And guess what? The Supreme Court agreed unanimously, struck down the Marijuana Tax Act. Marijuana was not illegal for that short period of time before Richard Nixon, in a huge panic, put in the Controlled Substances Act, which is what we have today. Not science-based, drugs just thrown on there based on pseudoscience and Richard Nixon's hate for the Black community and the hippies. So marijuana had to be on that schedule in the worst spot because that's what Tricky Dick wanted. Okay, there you go. You heard it here. And now you know. All right, folks, we're back. And this is a great time to talk about a really important subject, and that is drug-to-drug interaction. Cannabis is a drug. And when we're working with patients who are on other drugs, we need to be really concerned about this. So, Doc, let's talk about that. Let's talk about drug-to-drug interaction. What are you working with? How do you work with it? And what are the biggies?
This is absolutely the right topic. And I think, earlier in our conversation, we were talking about how this is a medication and comparing it to pharmaceuticals. And the funny thing is, again, on the political advocacy side, everybody wants to set up this juxtaposition, like cannabis is natural this and pharmaceuticals are terrible because they come from New Jersey and, whatever.
Oh, don't malign New Jersey. I have a lot of friends there, but you're right. That's their
wonderful state. They do own the pharmaceutical industry.
Right.
But all that being said, or maybe the point is that now they're mostly coming from India, but I don't know.
No, which is a scary thought.
Look, as long as somebody's testing to make sure that they're okay, then
And there isn't a good track record of that, right? Anyway, yeah, we could get on that rabbit hole, but.
All that being said, I think the real point here is that, as we were talking about, it is a medicine. And as such, if we're expecting it to have sort of real results in our body, there's a biological mechanism for that. And therefore, there's going to be a biological mechanism by which it is eliminated. And those things then contribute to interactions with other medications, right? I mean, that's typically what happens, is that you have two medications and they come down to be eliminated by some enzymes in your liver. And if those enzymes are free and available, then they do their job. But if they're busy with somebody else, then they can't do the job, right? And so it's
when they don't do the job, that drug just sits in your bloodstream,
exactly.
waiting.
Right, exactly. And of course, it's even more complicated than that, because sometimes you can actually induce the enzyme, meaning make more of it, and then you've got too much, and then the drug levels drop. And so it depends a little bit on which medications we're talking about and which enzymes. And it's unpredictable unless you just happen to have it studied and look it up. So, but, there are a bunch of chemicals in cannabis. And the two that we talk about the most commonly, right, are THC and CBD.
Right.
It turns out that the THC is not a big worry. It's not I wouldn't throw it off the table, but it's not a big worry. And that's because the enzyme that's primarily responsible for the elimination of THC is abundant and not terribly busy.
It's not used by a lot of the other drugs that you might
be used by some of them, but not the majority of them. Number one. Number two is there's just kind of more of it. So there's more capacity, right? So if you're taking another drug and it's sort of occupying 50% of this enzyme's time, that leaves the other 50% to deal with your THC. So that's great. But the CBD is the one where we see the problem. And CBD just happens to be metabolized by an enzyme that is responsible for most of the other medications that we use, and where that enzyme is kind of already pretty busy, right? So if you throw CBD into the mix, it kind of tips us over the edge a little bit. And then what's interesting is that these medications have different affinities for the enzyme. So, the enzyme could be busy with medication A, and then you put in CBD, and the CBD actually muscles out.
It does. It'll knock it off. It'll knock it off and say, you're not here, I'm here.
Right, exactly. CBD is kind of piggy that way.
Yeah.
So the bad news is that while CBD is relatively innocuous itself, the medication that it knocked off may not be. And if the levels of that go up, then we can get into a lot of trouble. And so, classic examples of this would be warfarin, which is a blood thinner.
Yeah.
Or clopidogrel, which is another one called Plavix that a lot of people are on because
Plavix,
of the heart.
very common. Mm-hmm.
A medication called amiodarone, which is a very, very
powerful cardiac,
powerful and dangerous cardiac medication.
Mm-hmm.
There's so many medications. The way they work is, a little bit is good, but too much is dangerous, right? Another one that thankfully doesn't come up too often is tacrolimus, which is a medication that people who have had organ transplants are on to prevent rejection. And this has come up for me a few times in my career, is that a patient comes to me for back pain, right?
Mm-hmm.
But it turns out that, having nothing to do with their back pain, they've had a liver transplant or a kidney transplant. And so you can imagine the scenario in which the patient goes to the recreational store or even to the medical store and says, well, I have back pain. And the guy behind the counter says, great, you need CBD, right? And they take the CBD, and whether or not the CBD does anything for their back pain, the real problem is that their tacrolimus level goes up, and that can be lethal, right? So, again, thinking about the pharmacy model, the pharmacist knows about drug interactions and
that's that's probably one of their primary trainings, is the drug to drug interactions, right? That's their primary responsibilities.
So they're going to flag that combination and say, we need to think about this. Let me call your doc or something like that.
And doc, think about it. People might have multiple providers, right? And one doc provides, prescribes this medication. You prescribe another one. Pharmacist looks at both and says, well, okay, hold on now. Let's make a call to both these folks and say, what do you want to do?
Both of those prescribing docs should have looked at the whole list and had a thought there. But
that is how it should work, right?
Right. But sometimes we make mistakes, and sometimes we don't know the full list. When patients come to me, we ask them for the full list of medications, right? Of course, until we get their medical records from their institution, we are only taking their word for it, whatever they remember or whatever they have written down. So it may be an imperfect list that way. And then there are the medications that people don't want to tell you about. There are 27 supplements or their Viagra or whatever it is.
And all of those have an effect.
Oh, absolutely.
Yeah.
Absolutely. And in fact, the supplements are really interesting because they're so loosely regulated at this point that we have very little idea what's in that capsule. And, leaving aside whether it's effective or not, we really don't have a great understanding of sort of how it factors into those drug interactions.
Right.
But clearly they do.
Right.
They're just not as well studied at this point. So they make me feel pretty uncomfortable.
Yeah, well, there are some that we already know, like St. John's wort. That is a very high capacity to interact with other drugs. And so, there's always warnings on St. John's wort, or at least in all of the sort of the drug reference guides. When I'm looking up a particular drug, St. John's wort shows up a lot. And that's just a natural plant-based extract, right? So, yeah, you're right. There are some most we don't know.
I think there's in the scientific community, there's sort of the expression, the fallacy of natural, right? I mean, everybody says things like, well, cannabis is better than pharmaceuticals because it's natural, it's a plant and stuff. But of course the thing is it's a plant and it makes all kinds of stuff, some of which might be great and some of which might not be great. Yeah. I usually say this, when people start talking about things being natural, I usually say, the reality here is that cobra venom is all natural. But it doesn't mean
plutonium's natural, but I'm not going to carry it in my pocket.
Right. It's a great example.
You're right. That's a good point. It is all natural. So I read a study a short while ago about CBD being a very high potential for taking up that enzyme. And they compared it to grapefruit, right? So a lot of medications, you say, don't say on the warning label for patients, don't eat grapefruit or drink grapefruit juice while you're taking this medication, because the grapefruit juice, whatever's in it, will take up that same enzyme, right?
Absolutely.
And so they compared grapefruit and CBD is like 10 times more
That's the thing.
Or much higher magnitude of effect on that enzyme group.
Exactly. So even the comparison to grapefruit juice is a little bit off because the magnitude is so different. The other thing is people are probably not anymore eating a grapefruit every day kind of thing. Maybe in Florida, I don't know. But, the days of sort of the all-American breakfast where you got up and you had your glass of grapefruit juice or whatever, I think those have kind of passed. But, if you're taking your CBD every day, that's obviously much higher dose, much more effective interactor. So we need to be aware of it.
Totally have to be aware of it. Totally. And I don't think that's why I wanted to have that discussion today, because I don't think it's talked about enough. I don't think it is. I have a friend who I hadn't seen in a long while. I love her dearly. She's an amazing person in her mid-60s, severe diabetic, on warfarin. And she had seen that I'm in the cannabis space. And she's like, I've been using cannabis for a while. I'd love to sit down and chat. So we had lunch and we chatted about it. And she brought all her products and she brought the CBD. And I said, so what else are you on? She's like, warfarin. I said, really? Said, yeah, but my levels are like going up and down and they're all over the place. We can't get it right. And I said, oh, well, let me just help you out here and explain why that's happening. So I had her go back to her doc and just dial this in. Right?
Yeah.
And still, it's not as if you can't use CBD, perhaps, but it has to be done in a very conscious, intentional manner with your doctor who's prescribing the other medications.
Certain medications, and warfarin's a great example, where we can, as you said, dial it in. We can do the blood test, the INR, and see where it is. And so at that point, if you get the CBD dose on a very consistent basis, and
at the same time,
right,
same dose,
that works. Other medications are less amenable to that kind of dialing in. Plavix is a great example. We really don't measure blood levels of the effectiveness of this medicine, but we do know that its effectiveness can be altered by drug interactions. And where this really comes up is that people are most often put on Plavix after they've had stents put in their coronary arteries.
And hugely important to not develop a clot with that stent.
You got it. I mean, because that would be potentially lethal, right? I mean, that's
absolutely
creating a heart attack. We don't want to do that.
No, not at all. So it's important. It's important to be aware. And that's what we're here for. We're here to educate. So it's important to be aware that these are possibilities. And especially in the group that you're working with for pain, the 65 plus. On average, they're going to be on 5 medications, right? I think that's what the average was. Once you get up into the 70-year-old range, you're probably on 5 different medications for different things.
I could believe that for sure.
Yeah. So hopefully, through the use of cannabis, you can decrease the amount of the number of medications that you're on and effectively work with it. But you need to have that professional healthcare provider working with you. I think that's our message, right? Work with a professional healthcare provider, someone who has knowledge, right?
Right. Yeah. Absolutely. I mean, you wouldn't do. I'd like to think that most people are not willy-nillying their healthcare in other arenas. I know for a fact that there's that more people are doing that than we would like, but generally speaking, I think if you sort of went down to your nearest mall, assuming that there was no COVID, and you asked people randomly, do you think people should get advice from their clinicians, or they should sort of just kind of throw their hands up in the air and take whatever they can get? I think most people would agree that getting some advice is not a bad plan.
Right.
And so we're in this weird industry where sort of getting advice from somebody who has the training of a Starbucks barista is kind of the way it's being conceptualized at the moment. And I think we can do better for people than that.
That's a great analogy. My barista told me that for my pain and anxiety, I should probably take this.
Right. Exactly.
Yeah. Oh, and cream and sugar with that too.
this might be a great moment for me just to tell your audience a brief bit about the Association of Cannabis Specialists.
Perfect spot.
So, because I got into this field a long time ago, where there really weren't very many physicians or other clinicians involved, particularly here on the East Coast, I set out to, have my practice kind of really take care of people. And what I realized was that there is not so much a lack of research and knowledge, but there's a lack of dissemination of that research and knowledge to our colleagues. And so I started the Association of Cannabis Specialists to help everybody kind of learn what they needed to learn so that they could do this properly. And also to sort of reinforce some of the professional behavior that we expect from our colleagues that somehow in the cannabis industry had kind of gone by the wayside. I expect that I will take good care of my patients and be available to them. And I send them home with my email address and my phone number. And I practically beg them to use those things. And I follow them closely. And I would expect my colleagues to behave the same way. And so that's part of the mission of the ACS as well. And then obviously, as we've talked about today, there's also a large component of the fact that because all of the cannabis programs are state by state, and they're all different, and they're all based on laws that were written by the cannabis industry, that there are some significant flaws in the way we are approaching cannabis as a medicine. And so a lot of the ACS work gets done on that advocacy side to try and kind of make this work more smoothly and sort of a little bit more like a pharmacy, and where we can actually expect that when we suggest to a patient that they get X, Y, or Z, that they will get X, Y, or Z and not ABC. And therefore, we increase the likelihood of our patients getting better, right? And that's the goal.
And having that positive experience with the cannabis as a medicine. Yeah.
Exactly. So,
go ahead.
If people want to check out the Association of Cannabis Specialists, the best way to do that is to head on to the web and go to cannabis-specialist.org. Again, cannabis-specialist.org. And there are a whole bunch of resources there for people and for clinicians. And if people are interested in joining for whatever reason, we welcome everybody, not just clinicians. And if they want to just support the mission, we certainly have a mechanism in place to accept donations, and we greatly appreciate that support.
Right. And so you and I met, a year or two ago, and I've been a member of the organization, and I absolutely love it. And my favorite thing, the monthly grand rounds. Now, we don't call it that, but that's what it is. It's grand rounds. So for those of you who are in healthcare, it's amazing. We get together on a monthly basis and we talk through specific use of cannabis as a medicine, and it's powerful and instructional, and just that peer sharing is an amazing moment to move this thing forward. So I would encourage any healthcare provider, as you said, anybody's welcome, but specifically healthcare providers, nurses, nurse practitioners, physicians, anybody in the space who's interested in learning more about cannabis as a medicine, join the Association of Cannabis Specialists.
Thank you. We actually do have a new program coming out that will be called Grand Rounds, which is going to be structured kind of as a review of the literature followed by discussion. So there's going to be a lot of sort of delving into the science, but then talking about how it's clinically relevant. And this is really one of the big things for the ACS is, anybody can go read the studies if they have the time and interest. Many of people don't have the time, even if they have the interest. So this is kind of a way to reserve a little time and to kind of get a guided look at some of the seminal research, but then really to bring it back to, so what does this mean to us as clinicians? And how does this influence our approach to taking care of patients? And so I think that's going to be really interesting. And then the mentoring stuff that you talked about, that's ongoing and
so
frankly,
powerful.
Fun.
It is. And it's powerful. It's powerful. It's how we move this forward. It really is. It's how we move this forward together. and learning and sharing experiences. It's an amazing opportunity for anybody who's in the space who's really trying to help people. Yeah.
Oh, one other thing we should mention, and I assume you've gotten some of our emails about this, but so the new grand rounds starts next Wednesday. So not tomorrow, but a week from tomorrow will be the first one. And then the following Saturday, which is August 1st, we're having this enormous symposium on genetic testing. Genetic testing for cannabis specifically, meaning testing human beings, for guidance as to how to use cannabis, has become very popular. There are 6 to 8 companies across the country that are actively pushing these diagnostic tests.
I took that a year ago or two, maybe, probably a year ago. I took one of the tests because I was curious. I'm like, is this just snake oil? Is this just a marketing ploy?
I think it's...
And it was interesting. It was fascinating.
Did it give you any real guidance?
Well, it gave me some genetic markers that said I probably should not be taking this particular substance, this cannabinoid over another cannabinoid. So there was some value there. I mean, it needs to be tested through, but yeah. But so there's a symposium coming up.
Yes. So it's Saturday, August 1st. Off the top of my head, I should know what time it will be, but I don't know. In the morning.
Where can somebody sign up for this? Do they have to be a member of the ACS?
No, it's free and open to everybody, and they can simply go to the website, again, cannabis-specialist.org. Or frankly speaking, if they're interested, they can email, which would be info@cannabis-specialist.org. That's probably the best way to get on the list. So again, info@cannabis-specialist.org.
And we'll have all that on the show notes, folks. So not to worry if you're driving, if you're sitting at home, wherever you may be, if you didn't write that down, it'll be on the show notes and all the places where you consume this content. So sign up. That sounds amazing. I mean, you just spoke to the closet nerd in me, and all of you said, like, the grand rounds, the review of the literature, and then how it's applied clinically, and the genetic testing. I mean, all of this science surrounding this amazing plant, that's legitimizing cannabis as a medicine. And you're at the forefront of this, Doc.
It's what we're aiming to do, because ultimately it's about taking care of the patient.
It is.
People ask, Doc, are you pro-cannabis? And I'm like, no, I am pro-patient. Yeah. If cannabis helps my patients, then I'm all for it. But it's not the plant that I'm interested in. It's my people that I'm interested in. And what's really interesting to me is the number of people who are really doing well using this medication in ways that they've never been able to achieve on other medications previously.
Exactly.
And so, again, getting back to our discussion of tools, why would we say, I need to drive in a nail. All I have is a screwdriver. There's a hammer over there, but I'm going to make that hammer illegal and make it so that you feel guilty for using or wanting to use the hammer. So you're just going to be stuck with a screwdriver for your nail. I mean, that's just crazy stuff. Right?
Love that analogy. Oh, so good. Yeah. So basically, pick up the hammer. Let's go.
Yeah.
You're going to drive the nail and you're going to feel better.
Use it carefully, use it with knowledge and forethought so that you hit the nail and not your thumb, right?
Exactly. Yes. Love it. All right. In the last couple of minutes, let's talk about something that everybody loves to talk about, Doc. Let's talk about sex.
Excellent.
You just dropped one out on social media about sex and cannabis, pros, cons, things. Let's talk about that because everybody wants to know. I want to know. I mean, I've had personal experience. I'd say check, very good. But let's talk about it.
I think that cannabis is another tool for increasing sexuality, increasing pleasure, increasing connectedness, all of those sorts of things. What we know through a handful of well-done studies is that, cannabis can really positively impact sexuality in sort of a whole bunch of different ranges that we have no other medications that can approach, right? I mean, if you take cannabis out of the equation for a moment and think about sexuality, the medicine that we have is, Viagra and Cialis and stuff like that, which are very effective for erectile dysfunction. But that's only one problem out of several that men have. And those medications do nothing whatsoever for women, right? So, we're sort of have medications that maybe approach 10% of the general issue. If you bring cannabis back into the discussion, it actually affects men and women. So you've just doubled your population, and it affects a whole range of things from loss of libido, difficulty with arousal, particularly in women, difficulty with orgasm, either not achieving orgasm or not achieving the intensity of orgasm that's desired. In men, it can actually be helpful for men who orgasm more readily or sooner than they would like. But I think the most important part is in the aftermath, the afterglow, as we used to say. Cannabis promotes the secretion of oxytocin, which is called the connectedness hormone.
Can't get enough of that oxytocin.
Right. So, cannabis is just a wonderful adjunct to sexuality. Like we were talking about using cannabis for other issues, there are sort of ways that you can approach it that are sort of more effective than others. There are a bazillion companies out there that are now making various types of cannabis topical lubricants, right, to sort of put down there kind of thing. And generally speaking, I don't think they're wildly effective, partially because it takes a long time for them to start working, which sort of, how many people in their sort of sexual process sort of want to put something on and then go about their business for
it's like, hey, put this on. I know we're in the moment, but I'm going to put this on and step out for about an hour, hang out. I'll be back. And then we'll try to rekindle this whole thing. Yeah, no, that's not.
Timing is everything, right?
Timing is everything. Right.
So the topicals, the other thing is that what we as organisms have a tendency to think about sex as a down there thing. But the reality is that 90% of sex is between the ears, right?
Right there.
And so if you put something down there, it's really not going to have much of an effect or any effect on the between the ears part. So I kind of think the topicals aren't a bad thing, but I don't think that they're as helpful as we'd like them.
There's one side note that I'd throw out there is that there was some research done on CBD being effective, not in vitro, but effective as a anti-cervical cancer. I don't want to say medication, but it has the proclivity to kill cervical cancer cells. So we don't know. We don't have enough research. Again, it's another thing you just throw out there. But it's possible. So future research, we could say maybe it is a good thing.
In test tubes, we have seen that THC and CBD both kill cancer cells of various types.
But does that translate into the human?
Exactly. And that research is definitely being done. More so still in the mouse model or in the test tube, but we're getting closer to understanding why it works, which then will allow us to develop, more appropriate human studies.
Right. So
I still think we've got, a decade or two
at least
research there.
Yeah, I agree. But exciting to be here. So back to the sex.
Oh yeah.
I'll tell you from personal experience, increased sensitivity. I mean, I'm 58, sensitivity is a thing. So increased sensitivity and connection, like being in the moment with my partner, being in the moment is much, much, much easier if there's a little cannabis on board. So I'm a huge proponent of that.
And you mentioned a little cannabis, right?
Yeah.
It goes a long way. And again, particularly for men, if you overdo it, you just kind of get too flaky to kind of be.
You start thinking about a ho-ho or a ring ding or
That's
a good steak dinner. Yeah, no, your focus is gone. You're right. So, microdosing, right? Just that microdosing, just that little bit, just takes that edge off and really gives you that focus and that increased sensitivity. Huge proponent.
I think the other thing that comes up is that, people like to make these kind of multi-course, fancy cannabis-infused dinner type things as a romantic gesture. And generally speaking, I suggest people actually not do that. That is to say, I think that making a nice, fancy, multi-course dinner is a great way to start a romantic, evening or whatever. But when you start to put cannabis in it, not only for many people that kind of ruins the flavor of the nice food, but the problem really is getting the dose right is very difficult.
Almost impossible.
Almost impossible.
Yeah.
Literally. And then the other thing is that because it is so unpredictable in the time to onset, right? So you want you and your partner to kind of hit that sweet spot at the same time, right?
Yeah.
Not 20 minutes apart or 40 minutes apart. So what I generally suggest to people is vaporized cannabis flower, and you can work that into foreplay. But the thing is that works for pretty much everybody within the first 10 to 15 minutes. So
absolutely.
Everybody revved up kind of at the same time.
Yep.
Whereas the edible stuff is very useful medically, but in this particular instance, it's just very hard to get it to work properly.
Right. Great advice, Doc. Absolutely love the conversation. Thank you so much for being a guest on the podcast again and sharing your wisdom and knowledge. If people want to get a hold of you directly, how can they get a hold of you? We'll have all of this on the show notes, but I always think it's a good thing for you to talk about it a little bit.
Sure. So my practice is called inhaleMD. And so not surprisingly, on the web, you can find us at inhalemd.com. Again, inhalemd.com. If you're old school and you want to give a call, that'd be great. It's 617-477-8886. And email, you can email office@inhalemd.com.
Awesome. And you can find Dr. Jordan Tishler all over the web and social media, LinkedIn, Instagram, Facebook.
Facebook, yes. Instagram, no. I've never been sure what to put on Instagram because obviously I'm not putting pictures of my patient, and I'm not going to put pictures of balls of weed. So I was a little bummed with what to put on Instagram. But yes, LinkedIn, Facebook, Twitter, Jordan Tishler MD on Twitter. And the other thing is on that website I just mentioned, inhalemd.com, we've got a blog section with well over 100 articles on all sorts of topics.
And I'm talking fabulous articles, folks. Like these are really, really well written and to the point. And Doc, thanks again for being a guest on the podcast. Appreciate it. And we'll have you back again.
I'll look forward to it because this is great fun. Thanks, Mark, for doing it.
It's fun. All right, folks, that's a wrap. Well, hey, thanks everybody for tuning in to this week's episode of the Nurse Mark podcast with my guest, Dr. Jordan Tishler. I hope you enjoyed it. I hope you learned something about what's going on in the cannabis as a medicine space and the work that Jordan's doing at a very personal level to advocate for cannabis as a medicine. And I hope you heard about sex and cannabis. If you got one thing, that's the one right there. Okay. So you know what I'm going to say. This is the only day we have. Make it the best day ever.